So, what's up today? Today we're gonna start putting things together, and I see this. I'm gonna take this out of the picture here. This is just for my dog, for my little dog. Sometimes he's here with me in my academy room. Okay, so welcome back for those of you who have been with us a few times already, and welcome back to all of those who are new. And I'm very happy that a lot of people are looking at these videos also after we recorded them. So yes, you can join us live. Also on Zoom, you can join us to talk with us. We're recording everything. We have it on Instagram TV. We have it on Neurolog Academy TV, which is our YouTube channel. You can also sign up for that if you want to. We will be posting new stuff all the time about functional neurology. So this is what we talk about, and if we talk about functional neurology, of course this is about functional medicine. Something that medicine is not taking care of properly. So there are guidelines about functional problems in people, and there are assumptions those guidelines have about the origin of functional issues. It's the brain. Oh, surprise. So now I'm still having discussions with insurances here and there about what is this, what I'm doing. I'm doing neurology. Are you a neurologist? No, I'm a functional neurologist. What is that? Well, we do this and that. So why, how long is it going to take until everybody understands that the brain is for real, and we need to look at the brain for functional aspects, not only for neurological disorders like Parkinson's, etc., but we also need to look at the brain for normal disorders like knee pain in everyday patients coming into my practice, especially if the MRI and the CAT scan and the X-ray and all these things are all not showing any problems, or even if they are showing some problems, which is usually the case if you're beyond 40, so you have some mild arthritis or something like that. This is not probably, or maybe not the problem, or probably not the problem. So what we want to do today is take everything together again, everything we have talked about, and bring it into like a clinical context. So we're going to go through all those aspects of the different parts of the nervous system, talk about those, talk about clinical implications and how we deal with those. Of course, I don't have anybody here today to show practical stuff. We're going to be doing that maybe next time again, but I want to just get the mindset, which is one of the most important things. To get the mindset into neurology is you have to think different. So you can't just think about, oh, my knee pain, oh, I have to think about all the ligaments and all that. Yes, you have to think about that also, because all of these are innervated, but of course you have to go into more an integrated view of what the body is dealing with. So I see a lot of things out there still dealing with biomechanics. I see quite a few things out there going into neurology, but a lot of that is just like sensory motor neurology. There's a whole lot more to functional neurology than just sensory motor system, proprioception, balance, all that. That's all very helpful and all very much needed, but there's a whole bunch of other things going on in the body: autonomic nervous system, the mind, emotions, so all these things. And we just want to look at the different parts of the nervous system again, go through that, and just kind of discuss where the problem could be if somebody comes up into the practice, maybe having knee pain, etc. So I need to find my pen, which is over here on the table, and I will be drawing a little bit. So what I found out, and I hope I'm doing this right today, what I found out technically is that all my videos were like flipped, because I'm looking at the screen so I can see if I'm in the screen still, which causes a problem because the camera flips the image. So when you look at yourself and you have a flipped image, it's easier to deal with that than if it's not flipped. So, but it's a problem if you record it, so I hope I got that fixed today. So we have a camera flip in there built in now, so this should be correct what I draw, and this should be not upside down. No, not upside down, but turned around. So let's start in the periphery. So we have some kind of tissue, whatever that is, fascia, skin, muscle, whatever that is. So this tissue has receptors. So there's like receptors in this tissue from a nerve picking up some information. So that's a transformation of information. So maybe this is pressure going onto the tissue, and this is then put into an electrical signal, and this electrical signal will travel along a nerve. So here we can already have problems. We don't know if we can really have receptor dysfunctions. So I haven't read anything about that, but I assume that's possible, because if you have a receptor turning a pressure signal into an electrical signal, it's doing work. If it's doing work, it needs energy. If it needs energy, it needs a blood supply. So it needs oxygen, stuff like that, ATP in the end. So if there is a lack of circulation, if you have some problem with the microcirculation, that might be a problem, not giving the receptor enough energy to work properly. So that could be. But when I play with receptors, when I treat the receptor level, I always also think about connectivity to the brain, of course, and the representation in the brain. And there's a question that comes up, is that really what's happening? So that's what we have in neuroscience. We have a lot of these things, so books and studies about how the brain represents the body, how the brain represents the exterior aspects, vision and hearing and everything in the brain. So is that the case really, or is it actually different? Is it maybe the brain looking for information, not receiving information, but looking for information? So is the brain maybe sending a signal to the receptor and looking for a match? So when I touch something, is that something I experience because I touched it and the signal traveled to the brain? Well, that's what we think it is, because we do measurements and we see the signals going one way or the other way. But maybe there is like a preset, a priming or something like that. That could happen, or is very likely through vision. Does that only happen in the brain? So when I look at something that looks flat, I expect something that's flat? Or is that something that's also happening in the receptor? So there's a lot of things to think about still in neuroscience. I think a lot of things maybe that would be changing if we go from the outside-in brain to the inside-out brain. So the brain making signatures that are matched to the environment or to things happening in the body. So that's just something for discussion, something to be found out, and we will be less unknowledged, is that how you say it? Less unknowledged tomorrow than we are today, which doesn't mean we don't have a lot of knowledge today. We have a lot of knowledge, but tomorrow we'll have more, and the day after that we'll have more. So every day I'm in my practice, I learn from my patients how to deal with these things. So receptor, the level of the receptor, then the level of the nerve, which is of course a system also consuming energy to transport a signal or to bring the electrical signal along the nerve. So blood supply is very important. That's one aspect. So if you don't have a good blood supply in your nerve, the nerve might not work properly. So this is of course something you have to check, and this is where interoception and visceral function comes into place. So we cannot only assume that we can just assume that this is going to be traveling here and then we can just deal with the brain. Absolutely no way. So we have to look at the nerve, and we have to look at the tissue, the surrounding tissue, in terms of interoception, visceral motor function, autonomic nervous system. We don't have that on board yet. So in our episodes, we talked a lot about these different levels. What we didn't talk about is the autonomic nervous system. So we're going to be talking a lot about that in the next sessions. So this is not coming into play so much when I explain this, but we have to think about it. So this is why I always say every time I treat a patient, even if it's a sensory motor system or proprioceptive problem, there's almost always the autonomic nervous system coming into play. So I think maybe Andrew Taylor Still, I was taught osteopathy after med school, or I did osteopathy after med school, and of course one of the things Andrew Taylor Still said is the blood, or the vessel rules, or the artery, or the rule of the artery. So blood supply, of course, is very important, causing a lot of issues if microcirculation is not working correctly, and that's also true for the nerve, of course. So how do you say that in English? Vasomotoric, so the motor system of the blood vessels is something that's critical to normal function. So we have a lot of things we can do in testing that in our system and also treating that, the reflexive systems in the autonomic nervous system. Of course, there's another aspect which goes more into the idea that we've been dealing with more in the past episodes, is with mechanics. So the nerve is a mechanical structure. It cannot stretch very much. It can stretch a bit, but on the other hand, the brain has to know what the nerve is doing. So if there's stretch coming onto a nerve, the nerve has to know. So it's not only the joints, it's not only the muscle, it's not only the fascia, it's also the nerve. So I assume there is a proprioceptive, if we talk about representation, in the brain concerning the nervous system. So the brain is aware of, where is my nerve? What is it doing? Is it stretched too much? Because if I stretch a nerve too much, it's going to get irreversible damage to the nerve. So there's a lot of studies on that. So there needs to be some surveillance. So the nerves that are in the nerve, on the one hand, they're giving the blood supply, or they're regulating the blood supply. The other thing is they're regulating the mechanics in terms of sending an information to the brain. We're fine here. So if that system's not working, of course we have to deal with that. So there's like two major issues with the nerve, the vascular supply and the biomechanics of the nerve, which are two different aspects. So one is more a proprioceptive issue, the other one is more an autonomic issue. So once we got that done out of the way, so nervous system, of course we have the spinal cord. And the spinal cord for some is just like, yeah, well, it's just, a bunch of cables going up and down. That is absolutely wrong in my view. We don't take enough care about we don't care enough about the spinal cord. We always talk about the brain. There's a lot of things going on, of course, in the brain stem, but there's so much going on in the spinal cord, especially concerning the motor system. So the motor system, most of the parts regulating muscle function are through the central pattern generators is sitting in the spinal cord. So the top part is just kind of like putting it together with the environment, but all the automatic stuff is going on here. So of course, this is something we need to test. So if a patient comes in with a knee pain and he does not have any history of peripheral dysfunction in terms of trauma to the knee or surgery to that area, there might not be so much going on with the proprioceptors. There might be something going on, of course, with the nerve, but there probably will be something going on in the spinal cord. So we need to find that out. So how do we find that out? Well, we do a lot of testing of integrated muscle function. So I don't know if anybody else teaches that. I really honestly don't know. But we don't just teach muscle function in terms of testing a muscle, seeing if it's facilitating or not. We test integrated muscle function, which means that we test the system, the sensory motor system in the periphery in relation to other parts. And I truly believe, and I don't know if that's really the case, but I truly believe that there's intersegmental communication in terms of, well, if I move this arm forward and I move this leg forward when I'm walking, that's not something that's happening so much in the brain. Yes, maybe, like we said in the mesencephalon, we have the nucleus ruber, the red nucleus, which is there to integrate top and bottom function, but also on the spinal level, the central pattern generators, in my view, will communicate over the spinal cord to agree on what's going on here. So if I test people like for muscle function in the leg, I always at some point will associate that with other parts of the body. So what's going to happen with the muscle function in my leg if I raise up this arm or if I raise up this arm? Something needs to happen, because this is not how we walk. We don't walk this way like a camel. We walk this crosswise, that's how you say it, crosswise. So we walk this way. So this information has to be conveyed somewhere down and up. So if something is happening in the leg, it needs to be transmitted to the arm, and I believe that the major part of that going on is the spinal cord. So the spinal cord is a motor system, and the spinal cord, of course, also needs blood supply. So the problem could be a connectivity from one part to the other, which for me would be an electrical problem. The other problem could be like vascular supply. So if I fall on my back, or if I have a compression of my spinal cords because I fell down maybe a couple of stairs and I fell on my buttocks and I have this compression, I see that people would show with more vascular issues also in the spinal cord. So the spinal cord has a huge blood supply. If you look at a spinal cord, and I already said that once, if you look at the spinal cord, the blood supply, it's just a huge blood supply. So because there's a huge energy demand, and if that's not working, you will have segmental problems, which could, of course, show up on both sides. So you might have somebody who's saying, well, I don't have knee pain on my left, only I also have knee pain on my right. So I don't think about the knee anymore at that point, unless he says, well, I also had surgery on this knee, on the left knee, but the right knee, there's nothing there, but I also have pain, and the pain is even at the moment more on the right side than on the left side. So what's going on here? What's going on in this part of the brain? So this is brain. To me, well, maybe we don't call it brain, we call it spinal cord, but this is brain. This is our movement brain. So what's going on here? Maybe there's a lack of blood supply, maybe there's a lack of activation, because of course this thing coming down here, and this might be a motor neuron, is also paralleled by other systems going onto that system to manipulate, I wanted to say, to modulate the function. So serotonin, acetylcholine, glutamine, all these things, all these neurotransmitters are active in the central nervous system, modulating its functions. So the connectivity to other parts of the brain, of course, is very important, but also here the connectivity then maybe to the arms is very important. So we have this thing of 4 limbs needing to be coordinated, also with the back, of course, and all these things. So that's what the spinal cord to me is mainly about. Of course, we have some autonomic systems in the spinal cord where the sympathetic nervous system is coming down and going into the paravertebral ganglia. But the main parts, if you look at that, the main part is sensory motor, so it's movement. The main part is movement. So with movement, of course, associated is energy demand. So it would be wise if I have a system that moves, and interestingly, that also happens in the brain. So there's studies showing that from the motor system, from the motor cortex, you have, of course, your tract going down to the muscle, but you also have a tract going from the motor cortex, so from that cortex into the adrenal glands. So the adrenal glands are activated. So if I start moving my leg because I want to, because my motor cortex is saying, well, move your leg, at the same time, there's a neuroendocrine activation to get to the energy demand, because we have to change our energy demand right away, not until it's too late, not until, oh, now I'm running out of energy, that's too late. So I have to take care of my energy demand right away. So that's a co-activation through the motor system to the autonomic nervous system right there. So that's part of the deal. So this is what I think spinal cord is all about, or mainly about movement. So that's why we need to look at that very closely if we have movement disorders. We cannot only look at the parts that are above that. And that would be, the next would be like the brain stem. So I'm going to simplify that in my drawing. So here's the brain stem and here's the cerebellum. Of course, what's happening here, it's getting more integrated. We have some integration here, left, right. On spinal level, we have integration top, bottom, and now it's getting even more integrated, things coming in. Also from the top, of course, going into the brain stem, saying, well, what is the environment I'm moving in? So I can move without any information about the environment. That's possible. So I can just close my eyes, I can put some headphones on, shut myself off from the environment, I can plug my nose, and all of that will still not cause me not to move. I can still move. So I can just kind of feel, but even if I didn't have that, it would be hard if I didn't have anything under my feet, any feeling under my feet to move around. But probably even that would be possible, you know. Floating tanks where you kind of lose the sensory information, you start to hallucinate maybe, but I think you can still move around, maybe like a baby, but maybe not very coordinated. So a lot of things coming in from the outside here, especially at the top part. So the mesencephalon, this might be too small so you don't see it, but that's why I'm saying the mesencephalon is one of the main areas where external information is integrated with body information in terms of movement. That's where movement is initiated, the mesencephalic locomotor region. So that's where we can start moving towards a target. So that's what I'm saying. I'm hungry, I'm looking for something, I want to move toward that, I want to maybe grab that, so I have to interact with that. And that's what they're saying. This is where mainly not autonomic motor system, body, and external environmental cues, information, signals come together to make a movement according to the environment. And this is an interesting part of the brain, because if people are not able to see because the visual system is not working, they might still be able to see, if it's not the eye, if the visual system is not working in the cortex. So the eye is sending information to the mesencephalon, and people can navigate in a room with objects. They can move around the objects, but they just don't know why. They don't know why they're moving like that. That's because they're not consciously seeing it, but they can see on a different level, and that's the mesencephalon. So that will enable them to navigate even in a little complex environment. So a lot of integration going on, of course, a lot of autonomic systems. This is the largest proprioceptive part of the brain, the cerebellum. So that's a huge proprioceptive ganglion. Of course, on top of that, this is where I like to put SSD. This is like our storage for information. So if I talk to you about maybe going to the lake for a swim, everybody listening now thinking about swimming will think of a different lake, because unless everybody's living at the same lake. So we have different experience going into our everyday life and into what we want to do, how we want to move, etc. So this is a very important issue, because this is where individual things come into play. So if somebody has an experience, and that's what we experience, we don't only have external experiences like the lake we go to swim, or the Italian restaurant where we eat our pizza. And as I say that, somebody thinks of a pizza with vegetables, somebody else thinks of a pizza with prosciutto di Parma. So there's different aspects coming into play, but we also have experiences about our bodies. So last time I went up the mountain, my knee was hurting. The time before that also, so this was going on over the last months, maybe the last year, maybe the last years. So I have a whole bunch of experience. So what's coming into play is that somebody's saying, well, tomorrow I want to go hiking in the mountains, and the brain is saying, well, all the last times I went, I had knee pain. So there's a very large likelihood that this has nothing to do with the knee anymore, it just has to do with the experience. And the experience can be very strong in terms of what we experience in that moment is colored by the experience we had in the past. So people are coming into my practice, and we always try to find out how much is this causing a different experiences by changing what's coming out of this. So you can change that, for example, just by asking the people, what is your thought now when you start walking about your knee, for example? And the patient might say, well, I think it's going to feel restricted, and I think it's going to hurt. So this will shape their experience when they walk. So never assume that what they're saying is what's happening right now in the knee. That can be quite a bit, like if the knee is really damaged badly, of course, but it can also be quite a lot coming down from the brain in terms of coming from the experience they had in the past. So here's one of our participants in our seminar. So I was asking, we were talking about emotions and mental systems, and we will be talking about this issue more later on in other episodes. So he was talking about his knee, and maybe I already told this story. That could be, he was talking, or I was asking, does anybody have acute pain? So he showed up, he said, yeah, I just played badminton or racquetball or whatever he was playing yesterday for 3 hours, and now my knee's a little bit swollen and it's hurting quite a bit. So he's coming up, and I let him walk, and he said, oh, yeah, can you feel it? Yeah, it hurts a little bit. Do some movement that makes it hurt more. So he does this little like trying out how, when he bends his knee, how that would feel with his knee. And he told me, well, there's quite a severe pain of maybe, I don't know, 4 or 5 from 10. So then all we did, we kind of talked about how long was he playing and all that. And he said, well, and he was kind of emphasizing that I played for 3 hours. So I just told him, well, just imagine you just played for 1 hour. So just imagine that, and now go back and bend your knee. And there it is, 60% pain reduction just by bringing new thought into the equation, okay? And this is dramatic. So I've had people who had 90% pain reduction. I've had people who had their pain was gone when they went into a different thought. And of course, I also had people where it changed nothing at all, because that was not the main issue. It was more peripheral receptors, integrated function of the body, but not so much the experience they had. So this can be a big deal. And if we don't hack into this, if we don't take care of that, and we just think about vestibular system and peripheral receptors and all that stuff, yes, we can get to a certain point, but maybe that certain point finishes after like 10% because the pain is just coming from the brain. It's always coming from the brain, but it's coming from experience. So years ago, and that's where this whole issue came up, I had a patient in my practice, and we were doing all this stuff. We were doing integrating and working on all these parts of the body, looking at all the muscles and all the movement patterns and all that stuff. And he didn't really change at all. He said, every morning I wake up, I have back pain. Every morning I wake up, I have back pain. So all we did, we kind of hacked us into this experience. And I mean, I can't show that right now how we do that, but basically we just go into that conscious experience in the brain, and we're going to activate his memory. So he's there on the table, and he's just thinking about him getting up in the morning, experiencing pain, and then we started working with that, integrating that the way we work on the body and the brain. So here it comes back the next time. He says, well, my pain is gone now. Thank you very much. So he was just experiencing experience. So he was just re-experiencing what was going on for years. So there was nothing about the back, although I cannot say, maybe because I treated his back before, that part of the equation was already gone. So that could be, if I would have gone to the head first or to the mind first, maybe that would have not changed his pain so much as it did in the end. But on the other hand, his pain did not change at all working on the body. His pain only changed working on the brain, working on his mind. Okay, so that's why. And this is part of the brain. This is like the mid part of the brain where you have like hypothalamus, hippocampus, all those parts. This is very much simplified. I'm very aware of that. So experience comes into play, individuality, so the people have their individual lives. So that's what's going on at that level. And maybe that's too much simplified. Maybe that experience is in all parts of the body, all parts of the brain, even in the periphery. We don't know that, but this is where we assume a memory function. So like hippocampus, temporal lobes is sitting there. I think that's quite well established, although we don't know what's going to show up in the future. So we might have cortex also, but in my experience, the cortex does not play such a huge role in these issues unless, because it's the outside of the brain, unless somebody had head trauma. So if you have a head trauma, if you have a trauma to your skull, you might get a dysfunction in the nerve, especially like the cranial nerve 5, the trigeminal nerve, that's sitting in the sutures, that's sitting partially outside, going through the sutures outside in the scalp, that's sitting in the inside, in the dura, in the other meninges, in the vessels, in the exterior blood vessels, the extrinsic blood vessels of the brain, which are mainly there to regulate the pressure inside the head, but they're also there to supply the most outer parts of the brain with blood. So if you have a trauma to your head, you might get a dysfunction in cranial nerve 5, causing a dysfunction in blood vessel supply, causing a problem in the associated or in the brain areas in that area. So if you have a head trauma to the temporal or to the parietal part of the head, or to the sagittal or to the coronal suture, you might get motor dysfunction in parts of the body. So if somebody comes in complaining about knee pain, and we've checked peripheral system, we checked nerves, we've checked integrated function, and we checked his experiences and all of that, of course, if he comes in and he says, well, I didn't have any problem with my knee until that head trauma I suffered, well, we start up there anyways, because that's what could be causing the problem. So this is like the most important thing for me for the cortex is more the supply, the vessel, the blood vessels, the lymphatics, all that in the head. So that's a very heterogenic innervation. So you have cranial 5, cranial 7, cranial 9 that are involved. You have the sympathetics going up here through the ganglia to the head. Those are involved. The cranium itself, the bone, is embryologically made out of nervous tissue. So the neurocranium, where the brain is sitting in, to me is a nervous tissue. So that's how I treat it. And if there's a dysfunction in the cranium, you will very likely, that's my experience, have a dysfunction in the associated brain areas. So that's going to cause a dysfunction, for example, in the cortical spinal tract, which innervates 50% or has a 50% innervation of your distal limbs, so arms and legs. So more distal peripheral problems in those joints here could be a cortical motor problem. This could be caused by head trauma. So the patient case history is so important to ask them. Did they have whiplash, which could cause problems in the blood supply, in the lymphatic systems, in the cranial nerves, or trauma to the face or trauma to the head? A trauma to the face can cause dysfunction to cranial nerve 7, which is involved through the superior salivatory ganglion nucleus, not ganglion, nucleus, in the blood supply of the pterygopalatine ganglion, if I'm not incorrect right now. So that's then causing blood supply issues in parts of the brain. So that's very, very important to have a very close look. And of course, you need to test all these levels. You have to look at them. So you have to look at the receptors. You have to look at different stimuli. How do they affect nervous function or sensory motor systems? You have to take care of the nerve. You have to look at the integrated function through this. You have to, of course, look at the spinal cord in terms of autonomic supply. You have to look at the brainstem, more integrated function here for all parts of the body. Movement, of course. Here we have eyes. We have the eyes with information coming in. We have the ears with information coming in. We have the nose, which is like the olfactory bulb with information coming in. And we, of course, have the vestibular system in the inner ear with the 3 canals, and with the utricle and the saccule. So all these are putting information into the brain stem, supplying the brain stem with information, but also, of course, cortex, which is just higher resolution. That's what the cortex is. It's much higher resolution than the brainstem. But the brainstem for very basic reactions, of course, to sound, to what you see, that's enough information to cause a primary reaction, maybe to threat. So to protect yourself. So protection of the body, protection of the neck. People coming in with this kind of posture because they're constantly protecting their neck from whatever. That's what you need to find out. And the history of the patient. So we're going to be talking more about that. And of course, autonomics. This is one of the issues we'll be talking more, because that will cause maybe motor function through autonomics, regulating heart rate, exercise pressure reflex, probably also going through the brainstem, probably a whole lot also going through the paravertebral ganglions. So we need to look at that. Of course, that's part of what we do when we treat a patient. We look at all these issues. That's integrated function. That's functional neurology. With no excuses, with nothing we leave out. So we don't leave out the mind, the emotions. We don't leave out the autonomics. We have it all in there. That's how we have to go at it. All we have to do in the future is prove it. Yes, I have enough proof in my practice. I have treated, I don't know, a couple of thousand patients. I've done 30,000, 40,000 treatments. So enough proof to me that it works. Not all the time, of course, but the more you know, the better it gets. So yes, this is what functional neurology is about. So thank you for showing up, coming by. I'm going to say hello. We will be recording this. You can give me a like if you want. You can also go to Neurolog Academy TV on YouTube to watch some other videos. We have the whole seminar 1, our whole fundamental seminar on YouTube for free. It's 18 videos. In the first video, you have the manual. And we'll be updating that shortly, but you can just look at that and learn stuff we are teaching. Of course, the fundamentals. We just had a seminar on fundamentals last weekend on the web. And yes, we will come back in 2 weeks to talk more about the brain functional neurology. And thank you for watching. I'm going to say bye-bye and see you soon.